Welcome to this cardiogenic shock / high-risk PCI session. My name is Abdullah Al-Anizi. I'm an interventional cardiologist from Kuwait. I'd like to welcome our panel, Dr. Andreas, Dr. Ahmed, Dr. Mirvet, and Dr. Khalid. Today we have a 45 minutes session that's sponsored by Abumed and ATC. We will discuss the use of MCS in high-risk PCI and in cardiogenic shock patients. We're going to highlight the evidence behind their use and the impact from hemodynamic standpoint. The way the session will run, we have one case of cardiogenic shock, followed by a topic about cardiogenic shock and MCS, and then high-risk PCI with the MCS, and then a topic will be discussing the use of MCS in high-risk PCI. So Dr. Khalid will start with his first case. It will be a 5-minute case presentation, followed 10-minute presentation. If you have questions, please send them through the app, and I'll try to address them at the very end. We'll have 15 minutes for discussion and questions. Dr. Khalid.
So our patient is a 47-year-old gentleman who has diabetes, dyslipidemia, and he had CABG 3 years ago. So the CABG was LEMA to the LAD, and free REMA as a Y graft coming out of the LEMA to the first obtuse marginal branch and second obtuse marginal branch. So he presented now with non-ST segment elevation MI and diffuse ST depression, and echocardiography showed EF 25% with good RV function. So he was hypotensive with tachycardic, hemoglobin 14, creatinine 200, lactate 3, and he was on Levofed already 0.1. and mixed venous oxygenation is 55 with congested chest X-ray. So this is his diagnostic angiography, and you can see the circ is basically an AV groove circ with subtotal occlusion here, and the OMs are missing, and the LAD is occluded. And his right coronary artery, which is not grafted, is about 99% calcified. So because he is stage C, we put an impeller CP in him, and then did PCI to the occluded OM, which is here. So basically this Y graft, there is a LEMA goes that way, which is occluded. The LAD was occluded. And the REMA that is like a Y graft coming here, supposed to supply the OM1 and OM2. So his culprit is OM1, and the LAD territory is not really supplied or well perfused. So this is the description of the angiogram. So this is the PCI to the OM through the LEMA, REMA to that one. So we managed to open it. So he has good perfusion to OM1 and OM2. Day 3, pressure is good. Hemoglobin is fine. Creatinine coming down. Good liver function, lactate is coming down, off pressors, good urine output, and mixed venous saturation is good. And echo, his LV has improved a little bit, 35%. So it's time to remove the impeller. So since he has severe LV dysfunction and the anatomy, as you have seen, we thought we'll do the RCA while he's on the impeller before we remove it. So now we're doing like a high-risk PCI to this patient because he will need rotablation. We put a pacemaker, rotablation to the RCA, and opened it with a stent. And then we removed the impeller in the cath lab and closed the site with a ProGlide.
Thank you, Dr. Khalid, for this really nice and complex PCI. It's a cardiogenic shock and then ultimately became high-risk PCI. Dr. Andreas, you can go ahead with your presentation.
Yeah, thank you very much. So when we talk about cardiogenic shock in evidence, it always goes back to the old trial of revascularization versus medical therapy by Hawkman and all. And the important thing is that this was always treated as a positive trial. But if you look at it, it was 30 days was a primary endpoint in Today, it would be considered a neutral trial that is hypothesis generating because the evidence of a positive significant effect was only to be seen at an exploratory endpoint at 6 months. Nevertheless, it was deemed as clinically important to reduce the mortality from 56 to 47%, and therefore the guidelines always recommend that we should revascularize the patient. Now, when we do revascularize in cardiogenic shock, and that was a topic in the previous session already, do we want to quickly revascularize? Do we want to get in with a mechanical circulatory support system to support us and stabilize hemodynamics during the intervention? Do we want to do a complete job, or do we do it staged, as just seen in this excellent case? Many questions that haven't really been addressed yet. Now, today, after the last 2 years, we are in a very lucky position that we do have trials on almost all mechanical support in the setting of cardiogenic shock. Holger Thiele from Leipzig investigated balloon pump and VA ECMO in cardiogenic shock. Both trials were neutral with regard to mortality. They were adequately sized. Unfortunately, the majority of patients actually received the devices post-PCI, so it didn't really stabilize the patient during the procedure, and quite substantial number of patients had been resuscitated, so were prone to potential anoxic brain damage before. So given this neutral trials or no evidence, the guidelines had no other option than to say eventually this devices may be considered in patients with refractory cardiogenic shock. If you do not have evidence, you can't say much more than may be considered. It is obvious. But refractory cardiogenic shock, is it the right time? If we look at the pathophysiology, most probably not. We start with a hemodynamic circulatory problem in the beginning, but that progresses into a metabolic problem over the next 1 to 2 days. If we are in a metabolic problem and correct circulation, we might not be changing it back to where it actually started from. And the other thing is, after 2 days, a substantial amount of mortality has already realized, and we can't actually save these patients anymore. But it was the best the guidelines could recommend. Did something change? Yes, I think something changed, and that's why we are sitting here and having this session. The Danish-German danger shock trial. Initially, it was started by our Danish colleagues as a Dan shock trial, but due to a slow recruitment in the first years, we expanded the trial into Germany and tried to get a sufficient number of patients. The trial aimed to investigate the microaxial flow pump impeller on top of standard care therapy in STEMI cardiogenic shock, and the impeller unloads the left ventricle and provides active support in reducing the filling. And the primary endpoint was death from any cause at 180 days. This was not deliberately chosen, it was chosen by evidence, because 180 days were the one single point of time in the Hockman trial where the data were positive, and that's the reason why we looked at 180 days. What patients did we look at in this trial? We wanted to have a conclusion on the question whether circulatory support can correct the worse outcome in AMI-cardiogenic shock. We didn't want to have an impact by anoxic brain damage, and therefore we wanted a fresh, new acute myocardial infarction without resuscitation. This is a small fraction of patients, that is clear, and that's why it took so long to take the trial through. But we were aiming for acute onset, so STEMI or STEMI equivalent, the typical age, 67 years, predominantly male. We want profound hypotension or hypoperfusion, so at least SCI-C. Patients had to have less than 100 millimeters of mercury as systolic blood pressure or been on a vasopressor. So they actually were on average at 82. They had to have a lactate arterial of more than 2.5. On average, they were at 4.5. They had to have a visual impairment of LV ejection fraction without a history of heart failure. So ejection fraction had to be less than 45, was on average 25. They had to be randomized when shock was diagnosed, which usually was within 4 hours of symptom onset for MI. 84% were randomized in the cath lab, so predominantly very early treatment. 3/4 LED or left main, 3/4 multivessel disease, and excluded were comatose out-of-hospital cardiac arrests, because we didn't know what that would influence on mortality. We excluded right ventricular failure, because the impeller is a left ventricular assist device, and mechanical complications that should undergo surgery immediately. From registry data in Denmark, it was clear that patients with these characteristics would have a mortality of approximately 65%. And the benefit that the colleagues calculated as significant in terms of clinical objects was an absolute risk reduction of around 15%. And this was what the power calculation was based on. And now we have the data presented this year at ACC by Jacob Möller, showing that the mortality of 58.5%, so being within the range of 60, was reduced significantly to 45.8%, with an absolute risk reduction of 13%, which means we have to treat 8 patients with cardiogenic shock with this setting to save 1 life. And that is the first trial to have a positive effect on mortality in the setting of cardiogenic shock anyway. So using mechanical circulatory support might kind of bridge patients to another therapy and might kind of bias the readout. Therefore, we also assessed whether there is an impact on the combined endpoint of death, durable mechanical circulatory support, so LVAD, or transplant, and still for the threefold endpoint, again, there was a significant reduction by early intervention with mechanical circulatory support. There were adverse events. We shouldn't become about that, but there was more bleeding, or we go in with 14 French into the femoral artery. But I think we have learned a lot of things over the last 10 years from structural heart to minimize bleeding. In the beginning of the trial, there was a lot of use of GP2B3 inhibitors, which we don't use anymore, and the bleeding probably go down, decline, when we take more contemporary treatment. Limb ischemia was actually projected to be much higher than 5.6. Again, here we have learned a lot from structural heart work, what we can do predominantly regarding removal of the devices. One downside was the high rate of renal replacement therapy, also in the control group being much higher than actually projected. But we knew it, Mirwad mentioned it in the last talk, that we had data actually indicating from basic research that there should be better renal function. But what we see is no patient was permanently on dialysis. So all were off dialysis when the treatment ended in the hospital. And it was predominantly due to fluid retainment. And that is something that we see with mechanical circulatory support, that we can use much more fluid, and we do use much more fluid in these patients, independent from the device we use. Stroke was not very high increased, so still there is a number, we have to mention it, but it was on a low level, and sepsis probably due to the higher mortality, early mortality in the control group, not as often observed in the control group as in the interventional group. So in conclusion, on the data that is there for contemporary treatment with MCS and cardiogenic shock, AMI-CS is still associated with high mortality of 50 to 60%. IABP and ECMO have failed to demonstrate benefit in RCTs. The Impeller is now the only device and intervention reducing mortality in an RCT in the setting of AMI-cardiogenic shock. And therefore, PCI centers treating AMI and AMI shock patients should be trained to use this device in dedicated cases to improve the patient outcome. Thank you.
Thank you so much. Thank you, Andres. So we finished 2 minutes ahead of time, so maybe we'll address 1 or 2 questions. Anyone has any burning question about what's been said already? So let me ask you a question. So this is really impressive results with the Danger trial. So if you're going to change one thing in your practice to get results similar what we get in the Danger, what would you recommend that people do?
Yeah, I think it's thinking about shock, thinking about the revascularization, and thinking of mechanical circulatory support as part of your routine pathway. What we learned during the trial, we used Impeller quite often before already, but what we learned during the trial was actively, whenever just a myocardial infarction STEMI was announced on the STEMI fast track, predominantly if it was an acute anterior MI, the first thing people were thinking about was, is a patient in shock? Recognize shock, do measure the arterial lactate once you do your arterial sheet, and see whether the patient is already progressive in your SCAI class or not.
You know, to me, the biggest change in the mindset is that understanding that cardiogenic shock, when it starts, it's an issue with hemodynamics. And MCS devices can help your hemodynamics. But if your hemodynamics are impaired for a prolonged time, then the metabolic changes ensue,
Correct.
which your MCS doesn't really reverse. Mervit, you have a question?
So, Andreas, what do you think about the timing of mechanical support in the setting of an acute MI? I know there's data in the making of the unload trial where you unload first and then you revascularize. What are your thoughts, and what was done in the Danger shock? When was the Impella implanted?
That's a very good question to strengthen that point. Impella was implanted as early as possible when shock was diagnosed. So the absolute majority of patients had shock once they arrived in the cath labs, and by protocol it was implanted prior to PCI, and the delay was 13 minutes, even in this very, very diseased patient. Only 13 minutes to implant the Impella started and progress with your normal primary PCI work. And that is something to get it in mind. Yes, stabilize the patient and then do a proper shock once you have stabilized.
Khalid, do you have a question?
Yeah, I think the message that I got from this trial first, to get the benefit, you should detect and intervene early. This is one thing. You have to select your patient that you think they will benefit. So patient here are really ST elevation MI who did not have cardiac arrest. So the brain function is okay, and they did not include the non-ST elevation MI. The other thing is, because of the risk of bleeding is high, maybe a major factor that we can change is meticulous large pore access. You know, we take care of that really well with ultrasound guidance and follow it up closely. So I think if we just, do careful large pore access, that may even make the benefit more.
Yeah.
What do you think?
And then it's the one thing you have to think about, implanting your Impella very, very early. And when you think about that, you start another question from the review session, in my opinion, the femoral approach, because then we escalate to Impella very early, and we use the Impella sheet as a single access. We do not go for a second arterial.
Sounds good. So I think we move on to the, okay. Sure. Let me give you the mic.
Thank you so much. I think the Danger shock trial also shows us the results in two extremely efficient medical systems in the world, in Denmark and in Germany. The fastest ambulances, known for the efficiency. Does this only reflect on using the mechanical circulatory support, the machine, the Impella, or does it reflect on the entire system? I mean, if somewhere which doesn't have those cardiogenic shock teams in practice and just starting using the Impella, do you think it'll have the same results?
I think the very important thing is the cardiogenic shock team. You do not start thinking about that case once the case arrives. You think about how you treat patients like this before they come to your center, and you have a setup for it. Regarding the ambulance systems, it's an interesting point because the two countries are very different. In Germany, we cover acute PCI care with 800 hospitals. In Denmark, they're more or less doing it with 3. Denmark is a little bit smaller, but if you would extrapolate it into Germany, it's 28 centers. So quite different. So in Germany, you have 30 kilometers maximum admission distance. In Denmark, for Odense, they had a lot of patients coming in for 160 kilometers on an ambulance, and still they have the good results.
Perfect. So we'll move on to the next case presentation. We'll have more discussion at the end. Now we're going to move on with Dr. Ahmed Imam, interventional cardiologist from Chest Disease Hospital, Kuwait. And he will show us a case of not cardiogenic shock, but high-risk PCI with MCS support. Dr. Ahmed.
Okay, thank you, Dr. Abdullah. This is the case I'm going to share with you today. This is a 54 male patient. The history of diabetes, hypertension, peripheral vascular disease, documented left external iliac artery occlusion. This patient actually referred from the orthopedic hospital after falling from a height with multiple fracture and injury. He presented with chest pain, non-ST elevation, myocardial infarction was the diagnosis, but he was hemodynamically stable at that time of presentation. This is his echocardiography at the time of presentation, poor LV ejection fraction with apical and anterior wall akinesia. So based on all this data, we recommend to go ahead with coronary angiography. This is his right coronary artery, diffusely diseased, very calcified vessel. Even you can see the left system here without an angio. This is the left system, critical left main stenosis, 3-vessel disease, subtotal LAD. So based on all this angiography, patient was presented in the heart team meeting, but not surprisingly, patient was declined by the cardiac surgeons due to the clinical presentation and the comorbidities, together with the high likelihood, of course, of prolonged post-operative course. So the decision to go ahead with high-risk PCI. This is to share with you some of our thought of planning. We thought to go ahead with upfront Impella CB, given that he has left main 3-vessel disease and anticipating to go ahead to use calcium modification therapy and his poor LV function. The axis, we choose to go ahead with single axis for both Impella and the guide catheter. Lesion preparation, calcified vessels, of course, IVL and Rota is the option, IVS guided. A stent strategy, Kilot technique for left main, ramus intermedius, and for the LED, only balloon for the LCX if needed. This is the Impella upfront before the intervention. Single axis technique. This is the 14 French Impella sheath. This is the ProGlide Impella and 7 French sheaths, same axis with the Impella. The only thing I want to highlight here, try to go away from the Impella, from the middle, stick here in the diaphragm or there, not to injure or damage the Impella and not to cause too much bleeding. Then we started our intervention with the wiring of the LAD, some hypotension, and also the blood pressure come non-pulsatile. But we restored flow with a 1O balloon, that followed by 2O balloon, 2.5 balloon, just to create some space for the IVUS. This is the IVUS. We can see concentric, eccentric, and deep calcium in the LED. That followed by IVL for the different sites, left main, LED, ramus, IVL, different sizes, starting from 2.5 up to 4.0 IVL, C2, 120 pulses, just to modify the calcium before stenting. We started our strategy with Kilot. We put a stent from the left main, 4.038 from the left main to the ramus spot. Again, one other DS to the left main LED. That followed by kissing balloon, pot technique again, and this is our final result. So my summary, my case summary, this is a non-ST elevation myocardial infarction, severe calcified left main 3-vessel disease, his surgically turned down, protected PCI was chosen for the intervention of this patient. We had some intraoperative hypotension. We finally got successfully opened his left main LAD and ramus with Kilot technique. Post-PCI, we removed the Impella with the ProGlide, and patient discharged with EF 40%. Thank you very much.
Thank you, Dr. Ahmed, for a really nice result for really high complex, really bad anatomy, which we see very frequently in our region, small vessels, diffuse disease. So good job. We'll move on with the talk with Andreas about the high-risk PCI with MCS support.
Yeah. Again, thank you very much. And in addition to the conflict of interest regarding the shock, I must say, Mirad and me were sharing ERPCI writing group for the high-risk PCI on surgical turn-down patients. So just to disclose that. And that raises the first question: what do we do with a symptomatic patient with a low ejection fraction and angina? And this was an excellent case that was shown. What is the evidence? The evidence is CABG is recommended over OMT in this patient, is written in the guidelines, and this is based on the STICH trial and a 10-year mortality benefit. What do we have on data compared to PCI? No data compared to PCI, because we are looking at patients that are usually deemed inoperable. So we don't have them randomized to CABG. OMT versus PCI, they had a couple of small trials, and one 2 years ago, the revived BCIS2, but that was not the highly symptomatic angina patient. So they were recruiting patients with ischemic disease from outpatient heart failure clinics. And though it doesn't really reflect us if that trial was neutral, is that the right thing to do for a patient that is highly symptomatic? And the registry data show that almost half of the revascularizations done in these patients are done by PCI, even though no data recommended by the guidelines. But what to do if the guideline recommended treatment is not an option? So we have to assess the patient, the facility, different things to consider. Because now we are in an elective setting. It's not the emergency where we can justify a lot of things. It is a purely elective indication. So we have to balance PCI and surgical risk. We have the comorbidities, bleeding risk, frailty, viability. We have concomitant vascular, cardiovascular diseases in addition to the complexity of CAD. We have our experience, surgical experience, MCS experience. The ICU has to have experience if the patient does not have successful removal of a device in a cath lab, and we have to have the strategy for anything that comes beyond. Why do we talk about impeller? That is on the right-hand side. It's a simulation from hemodynamic parameters. What happens if we have such a patient? We do an intervention, we go into the last critical lesion, or it's a single vessel, or the only thing is a left main critically stenosed calcified. We go in with a balloon, we have 10, 15 seconds to do something that we sometimes call a quick and dirty job. But if it doesn't work all right, if there is a complication, if it's more complex, it's not enough because the patient will hemodynamically decline. If we insert an impeller beforehand, theoretically, we stabilize the hemodynamics. We still have the loss of contractility, but the device provides, in the beginning, the impeller 2.5, 2.1 liters. Now we have the impeller CP, 3.5 liters of cardiac output. The patient is awake. The patient doesn't really has pain. So we can do a very good procedure. And we now can shift our whole approach from quick and dirty, focused on one single lesion, to let's make a complete job so this patient doesn't have to come back. What patients are we talking about? We are talking about complex coronary artery disease as one point, the hemodynamic compromise, ejection fraction below 35 as a second point, and patient comorbidities that make it much more complicated. If all of them three come together, we have that cohort that we actually like to address with protected PCI. So can we compensate the high risk by mechanical circulatory support? And we do have clinical trial data, and it's already 10 years old. And so some people might say, oh, I've never heard about it. 29% reduction in major adverse cardiovascular events, including repeat revascularization at 90 days for impeller compared to balloon pump support. It's great. It's clinically meaningful. But at an earlier stage, the Data Safety Monitoring Board deemed the trial as futile, and they stopped recruitment before they had reached the patient numbers that they actually wanted to have. And the primary endpoint was 30 days, something similar to what we have seen in the shock trial. And at 13 days, the effect was statistically not significant. Now it was 15 years later than the shock trial, and the trialists look at the data and say, this is a neutral trial. It is hypothesis generating, please do another trial. So we do not have the substantial clinical evidence, even though it seems to be meaningful on a physician standpoint. The other thing is, we do not only reduce ischemic events and angina, we improve heart failure symptoms in these patients. And that is something that was nicely shown in the case just now, improvement of ejection fraction, leading to improvement of heart failure classifications after this kind of treatment. And when we do this treatment, again, now this is evidence-based from a large national Italian registry, where they looked at all their impeller patients, and they looked at the protected PCI patients and found that if the patients do receive complete revascularization once they get mechanical circulatory support for high-risk PCI, you have less complications later on, and the patients have a better outcome. So if we go for it, we do it really in a clean way, and we have to do it complete so this patient doesn't have to come back. And so in this consensus that we wrote, we actually defined 9 steps that we should go through, and there were a couple of these points were nicely shown in the planning of the procedure that was presented as a case. We have to define overall risk. So this patient usually has high surgical risk and a high PCI risk. And then we do the same things that we do for CABG, for TAVR. We do a team approach, and we discuss it in the heart team. And once we've discussed it and say surgical is not an option, then we have to assess the peri-interventional risk, complex or renal failure, coronary anatomy, LV function. We have to discuss where is viability, what are ischemic territories, which CTO should be targeted to make a good plan, what is reasonable, and what is a stenosis or occlusion that the patient might profit from intervention. We have to look at the concomitant diseases, not only at the complexity, you've seen rotablation in that case, shockwave. This is an interventional thing, but if we talk about circulatory support, we should know, is there peripheral artery disease? What is the access to the heart? Do we have concomitant valve disease, which might limit our intervention? We have to assess the expected benefit. What will the patient gain from what we are doing? Do we improve heart failure symptoms? Do we increase ejection fraction and improve quality of life? I think you have seen it in that case that it, even on a short-term basis, can work very well. And then we really have to do PVAD evaluation. We are not going in blindly as we did 10 years ago and see what happens. We not only have a plan to do something at the heart, we have a plan how to get there and how to get out. So we do an assessment like we do it for any structural intervention when we go through the femoral artery. We talk about antithrombotic treatments. A lot of discussions also this session, previous session, about bleedings. We have to define whether a patient really has to have anticoagulation until the morning of the intervention, or if we can reduce bleeding risk by pausing it earlier. What intervention antithrombotics do we do? What's the optimal medical therapy? It doesn't start later on, it starts beforehand, on coronary artery disease, on heart failure, on risk factors, and then how the patient is handled afterwards in a dedicated care facility. Now, how do we finish? And that was also nicely shown in the case. We have to have a plan how to get out of the large bore access. And the ideal solution is, like in the case, we have a suture system that is pre-placed in the cath lab and is just taken when we take out the device afterwards. However, if we do not feel safe that we might take out the impeller directly in the cath lab, some people might try to place the suture device in a more or less sterile environment. Others will go back to the cath lab, use the side port access. We have seen this morning a case of how you can do a suture system over a wire in an ECMO explantation, or you deploy a Manta device. All the things are possible. Poor man's, you can even go to angioseals deployed within 10 minutes of each other, like we did it 10 years ago. It's possible. There's a surgical option, predominantly in patients where there has been a complication or where we had to rush in because it was not really elective, but high urgent, high risk PCI. But then the manual sheet withdrawal on ICU with manual compression and the placement of a femostop, I think, is the last option that we do once we do not have an option for all the others. The regular planned ones should be one of the above ones. So in conclusion, for MCS and high-risk PCI, many patients fulfilling the criteria for high-risk PCI are either not eligible to CABG or turned down, but still have relevant problems. Performing unprotected high-risk PCI often leads to a high peri-procedural risk for the patient. MCS can help to control the hemodynamics and thereby provide the time needed to do a proper job and complete PCI job for us. And the stepwise multi-professional planning before performing the procedure that reduces the risks and improves the outcome of patients. Thank you.
Thank you, Andres, for not only elegant but very sobering presentation. So we'll open floor for questions. Anyone has questions on both topics, protected PCI and cardiogenic shock PCI? Please go ahead.
I think we lose some of the benefit of the mechanical support device because of the access problems. So in your studies and these things, what's the access problem in comparison to two groups together?
The access problem?
Access complication. So the benefit of doing the PCI successfully with mechanical support is offset by vascular complications. Is that Accurate, yeah.
Yeah. So for one, in the shock situation, you've seen, yes, there was vascular complications, but still the overall benefit in mortality was there. So it didn't counterbalance the whole positive effect. For the elective patients, I think we can limit the vascular problems. Not erase them, but limit them in a way that we didn't think about 12 years ago. What we've learned from everyday structural TAVI work, if we apply the same strategy to our access for high-risk PCIs that we do for TAVR, we do have a very limited number of vascular complications offsetting the benefit.
Yeah, the point well taken. I mean, you cannot take the vascular access lightly. You have to use proper technique, fluoro-guided, ultrasound-guided to make sure your access is done properly. Dr. Khalid?
What's interesting here is the options to remove the impella, like 5 options. The last one is the manual compression, which is, I think, from what I have seen in the centers in the region, the first option is manual compression. They just take in the CCU and do compression. So I think that's an important point. It's your last option is to do the manual compression, not first option.
Your bailout, this gentleman, then go ahead.
Thank you for a nice presentation. I have a question about acute myocardial infarction with cardiogenic shock. Sorry, in this trial in Denmark, how much is applicable and how much percentage of they were applicable to enter in the trial, in the real, yani?
What percentage were excluded, you mean, from the trial?
For example.
Yeah, it was, of all STEMIs, it's a small fraction.
No, in the shock, patient with shock.
Yeah, also of the shock patients, it is a smaller fraction because we all know that a large proportion of our shock patients do have rhythm disturbances, arrhythmias, or had arrest. That is, if we do our registry, we see a lot of patients with impella having had cardiac arrest. They were excluded, but for one reason, not because we thought we were ineffective, but for the reason that it has been seen, in, for example, in the culprit shock trial, that there is a great contribution of anoxic brain damage to overall mortality. And we wanted to get rid of the anoxic brain damage just to have the possibility to show
how much
a proof of principle.
10%, 15% in Denmark?
Of the shock patient, it was about 10% going in there.
Okay, I have a comment, sorry, for about also using a heart team discussion in a patient. I'm an interventional cardiologist, and in many cases we are working at night or emergency cases in these patients, and the decision we're left with, we will take the decision only, and we don't have a heart team to discuss.
For shock, you don't need a heart team.
Okay.
You have a protocol.
Even in sometimes we should make the decision, and usually the surgeon will not do anything for us. Thank you very much.
Perfect. Dr. Mirvet, you want to?
Yeah, I wanted to ask you, Andreas, and perhaps the panel, when we're talking about high-risk PCI in surgical turndowns, I think we have to bear in mind residual syntax score. So those who end up getting partial revascularization compared with those who get complete revascularization do worse.
Yes.
And so we do have to take into consideration whether we can offer complete revascularization to patients percutaneously, even if we're using mechanical support. So what are your thoughts on that?
My personal thoughts are for both, for shock and for the high-risk PCIs, that we should offer as most complete revascularization as possible. But then still, it's not about the anatomical complete revascularization. We don't have to open up CTOs that go to necrotic areas. That was overdone in one or the other trial, I think. If we look at culprit, for example, it has to be reasonable. If there is viable myocardium behind it, we should have a strategy to treat it within that time that we do the high-risk or protected PCI.
Ahmed, you want a question? Short question and short answer,
a good
because you have 3 people
about
waiting.
using the MCS with high-risk PCI. It gives you time to optimize your lesions. You use atherectomy devices, do more inflation in left main, for example. You have backup to just support you.
Correct.
This is what I was thinking, because it's not only complete revascularization, but proper job.
Yes.
You don't want this patient to come back like the live case they did yesterday, someone who had the left main PCI, but it wasn't, the patient came back because of instant restenosis, right? So because they had an impella, they took their time to optimize the result.
To finish your job.
Your question, please.
Yeah. Speaking of the vascular complication, I think most of us are using impella for support and doing the procedure through single vascular access. My question to you, if you do this through single access, would you use another access to do control angiogram after using multiple suture-based vascular devices? Because sometimes you end up with no bleeding, but with stenosis in the femoral artery.
Also, something that we've learned from the structural work, that we sometimes, in these cases where we have the single access, we want to control and not stick in another artery for whatever, that we do pre-place the suture system, even in a shock patient rapidly in the beginning, and then use one prostyle, and then insert an angioceal afterwards, and you can do a microinjection over the angioceal deployment. And then you have your control that you have nicely no bleeding, and then you can just finalize it.
So we have a question here.
Yes, I just want to say that the rationale for mechanical support in shock patients is something, and in high risk is another issue, because you cannot just, for reimbursement issue, that you can use it routinely in every high-risk PCI with this high cost. So do you think we have enough evidence at the moment for high-risk PCI without cardiogenic shock to use routinely this thing?
It depends on how many patients you have. When we started our Impeller program, we actually thought we would do a lot of high-risk PCIs and one occasional shock. And then we realized that we do a lot of shock patients and occasional high-risk PCIs. It is a decision in your center with your facility what you accept as the high risk. It's not ideally what is written in the Protect 2 inclusion criteria. They are very widely written. And you have to choose it wisely with whatever situation you are faced with. So if the reimbursement is liberate, you use as liberate. If your reimbursement is limited, you will have a very focused use of the device.
And I think an important concept is that the patients are not either low risk or high risk. It's a gradation of risk. So depending on your resources, you can restrict it to the very, very high risk and then loosen it up as the resources get better.
Just a quick point about the evidence. So if we're looking for evidence in high-risk PCI in terms of hard endpoints like MI and readmissions and so on, there may be some positive data there. But if your outcome is procedural success, then yes, it does help in some procedures where you cannot do a rotablator or what have you in a patient with last remaining vessel without support. So for acute procedural success, yeah, it is an endpoint.
Two short comments. The one is, though the patients who were out of the hospital cardiac arrest as well as with the mechanical defects, they were excluded in the Denger trial. But in the real life, if suppose the patient comes to us out of the hospital cardiac arrest and reaches a cath lab and is in cardiogenic shock, or the patient of even the mechanical defect, they will certainly receive the mechanical circulatory support at some stage, definitely. I mean, if you are going to do the PCI. So, of course, in the trial, they have excluded the patient to look into primary endpoint, which does not get affected by these type of the patient. That's number one. Number two, in the high-risk PCIs, of course, as people said, there are the newer iterations of the devices which are going to come, which will be possibly the 9 or 10 French. You can put it for a shorter period of the time, so it will offset whatever the excess site complications currently we are seeing with the large bore devices.
Yeah,
Thank
you. And just with one comment to the cardiac arrest patients, obviously it's discussed in every center, and it's right, by the trial we have that as an exclusion criterion for the trial, but then we also have an eCPR program for ongoing CPR, and we have criteria which patient does receive ECMO for eCPR, like has to be shockable, has to be witnessed, has to be had bystander CPR. Now, if the patient is so lucky that he does not have ongoing CPR at the moment of hospital admission, but has ROSC 2 minutes earlier, which actually is good on a prognostic side. 2 minutes later, we would have given him an ECMO, but now he is better. We don't give him an impeller. No, in reality, we do treat patients that would fulfill the criteria for ECMO in eCPR. We do treat them with impeller if they had cardiac arrest, but that is our hospital policy.
I think there is one major issue here is cardiogenic shock is well-defined, definition is known, but high-risk PCI is, we don't have a definition for that. Anything can be high-risk PCI.
Yeah.
And maybe that's why we are deficient in the evidence in this group of patients. So when we talk, everybody said high-risk PCI, but we don't know what do they mean by it.
Okay. But I think that the patient groups that we wrote this consensus on, and it was difficult to get the consensus and get it published, but the group were in a hard team. The cardiac surgeon says, I decline this patient for CABG. This is certainly something else as, okay, this is a patient with an EF of 32 walking into the outpatient clinic.
Anyways, I hate to stop this really nice discussion. We cannot stop discussing PCI, high-risk PCI, cardiogenic shock. I'd like to thank our panelists and experts for their presentation, their effort. I'd like to thank you for coming. We've discussed cardiogenic shock and the use of MCS and how it can improve the outcome of our patients who are highly selected and inserted in a very sophisticated technique. And we also discussed the high-risk protected PCI patients and showing that highly selected patients can benefit from hemodynamic support that not only will give you a complete revascularization, but gives you the time to do a proper job to ensure the risk of having instant restenosis to be much lower in the future. Thank you so much.